This conference will now be recorded.
So hello everyone. Thank you so much for being here today for our presentation on the effectiveness of pneumatic compression in the treatment of hard to heal venous leg ulcers. My name is Jennifer Wang, the president of Paradigm Medical. We are a national medical products distributor specializing in wound care, lymphedema, post-mastectomy, and orthopedic footwear and foot care products. We are the exclusive Canadian distributor of biocompression systems, a Health Canada approved line of pneumatic compression pumps for the treatment of venous disease and lymphedema. We have been servicing all of Canada for over 25 years and are headquartered in Toronto. I'm very honored to be introducing our speaker, Dr. Alvarez, today. He is joining us from New Jersey. Dr. Alvarez was the program director of the Vascular and Wound Care Center, the director of clinical research at the University Hospital, and currently is professor at Rutgers, New Jersey Medical School and the University of Miami Miller School. Over the last 40 years, Dr. Alvarez has been a pioneering force in wound care and lymphedema. He is a founding editor of the journal Wounds and the managing editor of ePlasty. He has authored over 200 peer-reviewed publications relating to wound care and has been the principal investigator in more than 60 major clinical trials. What has impressed me most about Dr. Alvarez is his compassion. Many long-suffering patients have given up hope of healing, but Dr. Alvarez restores their faith by dispensing humor, compassion, and medical advice to everyone. So thank you, Dr. Alvarez, for your time here today and your energy. We are all very grateful to be able to learn from you. And so with that, I will pass it over to Dr. Alvarez.
Good afternoon, everybody. I'm so happy to be here, and thank you, Jennifer, for the very gracious introduction. So I'm going to talk to you about venous ulceration, the difficulty of living with it, and how to really take care of it, and how to heal and then stay healed. So basically, let's begin by asking you all, what do these patients have in common? And I know what I think right away. They all wear ugly shoes. But not only that, they have these polyester muumuus also. And these are female patients in our No Frills clinic dealing with leg ulcers. And they also have that in common. But let me tell you about these muumuus. I got one time when I gave the same lecture out in Indiana, and a nurse colleague of mine sent me a muumuu as a gag gift. And I wore it for Halloween one year, and let me tell you, darn comfortable, those muumuus. So I can't blame these fine ladies for wearing them. Next slide, please. About 90%, really it's 92% of all lower leg ulcers are caused by venous insufficiency. And really the amazing thing is, in medicine, we don't get too many times to guess and be right. But this is one of those where you can really kind of do that. And that's really amazing. Venous ulcers have many faces and many looks. Next slide, please. The epidemiology is shown here, and although this is United States, Canada is a good match for the US in many, many ways. Approximately 24 million Americans have varicose veins. Of course, that's the early sign, along with staining of the skin in the lower leg. About 7 million Americans have skin changes associated with venous hypertension. Venous ulcers affect about 500,000 people. And the mean incidence for hospital admissions is about 100 in every 100,000. The peak incidence occurs in women between 40 and 49, and in men much older between 70 and 79. We don't know why ulceration of the venous variety is more prevalent in women, maybe because of pregnancy or perhaps because of footwear, but we really don't know the answer. And approximately 2 million outpatient visits are due to chronic venous insufficiency. It's quite a burden to our health economy. Next slide. So venous ulcerations have many faces and many looks. However, they have certain things in common. They're all really superficial unless debrided improperly, but mostly are all superficial. The edges or the margins of the ulcer are serpiginous, and what that means is that they're actually up and down borders. They're wavy borders or margins. And if you look at venous ulceration, these wavy borders give you a good hint. They can be small and they can be terribly disfiguring, as you can see in these slides. However, treatment is always the same for these. Next slide. If you can catch the patient early without an ulcer, but with staining of the skin, we call hemocitrosity, and lower leg microvaricosity, like on the inside of the leg in the image to your left, inside of the foot there, in the medial aspect. Those are the early signs, and the hallmark of the disease is the staining of the skin, and we're going to tell you why that is. Next slide, please. Location is also a good classical tell all about venous ulcers. They occur in what we call the gaiter aspect or the gaiter area of the leg, and that's really between the lower ankle and about the mid-calf. And on the slide, on the panel on the left, you'll see that they occur basically where the perforators are. It's perforators on the medial aspect and Dodd's perforators on the lateral aspects of the ankle. Back to that other slide, please. Yes, there. And up in the medial aspect of the gaiter, the higher aspects or the more proximal aspects of the gaiter, where Boyd's perforators are. So that's the classic location of venous ulcerations anatomically. However, if a person has venous disease and they injure their leg, the wound can be anywhere on the leg. But basically, these are the most common locations. Next slide. So what happens is upon inflammation, cytokines and other inflammatory mediators are released, and inflammation is due to the venous insufficiency or the hypertension of the veins. This causes the endothelial cells, as you see in this picture, swell. And you just picture balloons when they're nice and uninflated, like just lightly inflated, you can hold 2 or 3 together. But when they're very inflated, you really can't hold them together very well. And this is what happens to the endothelium. When they get really swollen, they create these little gap junctions in between the cells, allowing fluid from the interstitial space to get out to the extravascular space. Next slide. So here you see a neutrophil, but a red blood cell can be the same way. This is a neutrophil with a little platelet attached to it, and you can see it leaving the 2 endothelial cell through the gap junction. And that's what happens when there is inflammation of the endothelium. These cells leak out, and as they leak out, they can cause, next slide, please, not only hemocitorosis, but they cause other problems too. So here in this cartoon, you see that not only do the cells get out through the endothelial gap junctions, but also fibrinogen, which when it comes out of the intravascular space, gets polymerized into fibrin. And what happens is you get this polymerized fibrin cuff around the actual capillary. Next slide, please. This fibrin cuff, as you can see here, this is an immunofluorescence slide showing fibrin around the capillary. And you see this fibrin cuff causes like a thick turtleneck around the actual capillary. When you have such a thick turtleneck, nutrients like oxygen and other growth factors can't get out from the vessel itself. And as they can't get out, the skin becomes starved, and that's how ulceration develops. Next slide. So venous ulcers develop insidiously. They develop slowly. And if you take a good patient history, you'll know that the history, they often don't remember when the wound first arrived because they develop slowly. However, it's most important that although venous disease is the most common of all lower leg ulcers, there is a differential diagnosis that I want you to be aware of. Really the major four are shown in these next four slides. This one is an arterial ulcer. You note that the borders or the margins are really smooth and very, very predictable, almost like a biopsy wound, very exact, smooth margins. And this can be any part of the lower leg. Next slide. This is an inflammatory ulcer called pyoderma gangrenosus of the cutaneous type. And as you can see here, the borders are smooth, but you get classical signs of central healing. You see how the wound heals from the center. This is a sign of how these particular wounds heal, and they're different from venous ulcers. They're much more painful and a lot more difficult to take care of. Next slide. Another differential is rheumatoid arthritic ulcerations, and these are inflammatory in origin and also can be in the same origin as a venous ulcer, but of course without hemocitrosity in this case, which is the hallmark of the disease. And next slide, please. The last one I want to mention is vasculitis, in this case lividovasculitis. This is in a patient who had terrible pain, and these ulcerations are extremely painful, very bothersome ulcerations. And the vasculitis and vasculitic ulcers are treated very differently than venous ulcers. But this is basically your four differential diagnoses that you should be aware of. Next slide. But remember one thing I want to tell you. Next slide. Chase the zebra. Next slide. But ride the mule. And in fact, that's what Bo Sanders indicated clearly a long time ago about general diseases. If you have statistics that show you that the percentage is great for a particular wound type like this one, 90% of all venous ulcers of all ulcers in the lower leg are venous. Chase the zebra, but ride the mule. Again, you need to look at the differential, but more than likely it's going to be a venous ulcer. Next slide. Good differential diagnosis table here tells you very big specifics about venous and arterial disease. The location, again, I mentioned the gator area of the leg versus the non-specific location. The pain in the venous ulcer is burning and tightness, whereas an arterial ulcer is cramping and obviously associated with intermittent claudication or walking long distance or up a hill. And it's a different kind of pain. It's a cramping, sudden pain. Hemocitrosity is always present in venous disease, absent in arterial disease. Edema is present and again absent. Lipodermatosclerosis is that thickening of the fibrin that develops under the skin. And if you feel the leg, it almost feels like a calcium deposit under the skin, especially in the gator aspects of the leg. Dermatitis is very common in these patients. We call it stasis dermatitis or stasis eczema. It's very, very common. And again, due to that inflammatory response, releasing the cytokines and the inflammatory mediators creating a rash. Microvaricosities, as I showed you here, especially pronounced when you have your patients stand and have them weight bear and look at the inside of their ankles or the medial aspects of their ankles. The ankle to brachial index, which we're going to cover, is crucially important. And in venous disease, it's always normal, more than 0.75. And of course, in venous, there's a familial history. This is a genetic component. And most of these patients have thrombophilia. You know, hemophilia, you can't clot. These patients are all clotters. Next slide. The ankle to brachial index is a key test for you to have prior to using any treatment, and this will tell you whether you have arterial disease or not. And as the patient gets older, ruling out arterial disease becomes paramount. And if you are aware of doing an ABI or a segmental pressure, these are answers that can give you, you can do an ABI in your office. You don't have to send them to a vascular lab, but just using a blood pressure cuff at the ankle and a blood pressure cuff at the radial artery up in the arm and looking at the ratio of the two. Next slide. So these patients, especially as they get older, develop arterial disease as well as venous disease. And it's thought to be about 10 to 20% of these patients that have lower leg ulcers may have both diseases. And that's why it's important for you to manage them, because you'll need to know in order how to use the proper compression. Next slide, please. So in this particular paper, Humphreys and al. Studied patients with venous ulcers and also had arterial disease. And they found anywhere between 14, 16, anywhere between 10 and 20% of these patients have both. Next slide. But fear not, because compression can be helpful if properly applied. And this is a study done by Harvey Marovitz, and showing very clearly that when you bandage properly with short stretch bandage, you can actually improve the flow of arterial blood. Knowing how to use bandage and how to use it properly is a really big key. Next slide. Compression is the key and the cornerstone of management for all of these patients. It increases the interstitial fluid pressure, thereby pushing it back into circulation. It reduces hypertension, improves the function of the calf muscle if you are walking. If you are wheelchair bound or non-ambulatory, it's a different matter. Although we know that 20 to 30 millimeters of mercury compression is adequate, we don't really know what's optimal. We don't really know what is best for these patients, how much to actually squeeze their legs. And of course, as the leg gets bigger and the circumference of the leg gets bigger, compression bandages are not as effective. Next slide. So compression bandages basically are not a great amount of choice. You have either between a modified Unus boot, which is a 2-layer bandage, a 4-layer bandage, or even a 3-layer bandage. And in essence, all of those provide more compression or more actual tightness to the leg, to the lower leg. The Unus boot, everybody's heard about. The 4-layer compression is very common, almost exists in just about everywhere I know. And the 3-layer bandage I use sometimes when people can't really tolerate the 4-layer bandage, or the 4-layer bandage rolls down their leg because of the shape of the leg. Next slide. So this is Paul Gersten, who actually discovered the Uniboot, but it's really amazing. He was a magnificent scientist as well as a physician. He not only discovered the Uniboot, he discovered adhesive tape and H&E staining for dermatopathology. He discovered H&E staining, toothpaste, and of course the short stretch bandage. Next slide. So Uniboot was the original short stretch bandage, and I'm going to tell you why that's important. Next slide. So short stretch bandage, if you take bandages, you can stretch them. The ones that stretch a long way are called medium to long stretch. The ones that don't stretch at all are called short stretch. Short stretch bandages will not hurt you in any way because they're not providing non-working or standing compression. These particular bandages, the short stretch bandages, exert the pressure at rest or when ambulating, but best is when you actually work. So bandages can exert pressure for both, like elastic bandages exert it at resting and at working, whereas inelastic bandages only provide that compression relief when you walk. So it really doesn't do any harm to provide a short stretch bandage. Next slide, please. So when you begin to use compression effectively, whether it's with a bandage or with an intermittent pneumatic compression pump, as we're going to cover soon, the inflammatory mediators associated with the long-standing ulcers, these proteases that are there, all decrease. And this decrease in the inflammatory aspect of the wound itself, these proteases that are there, when they decrease in their levels, they allow for the provisional matrix to come back into the wound and allow for healing to take place. So compression is anti-inflammatory, and that's really an important aspect of the treatment. Next slide. And how great is it that you don't have to provide a drug for these patients? They can do so well with just a simple device, and it's really amazing. But you know, bandaging is an art, and I tell all the people that I work with, especially those that I train, I tell them that it's actual assurance for your employment. If you really know how to bandage well, you'll always have a place in a wound healing clinic because these patients ask for you. These patients know who they prefer. I have patients come in all the time say, I want Nancy. No one else going to bandage my leg but Nancy. And let me tell you something, that is so true. They just get really used to that. And here's an example of how bandages should be applied. From the metatarsal heads right to the infrapatellar notch, right underneath the patella, right underneath the knee, like a break there. And it's important not to stop anywhere in between because it causes lymphatic obstruction if you have any type of stoppage in between. Next slide. So the bandage and application of the bandage is really something that you have to learn and do often. And you have to learn also the curvature of the leg because in a particular curve, like in a thick leg, in a very thin leg, that you have a bone or a bony prominence, as you apply your bandage, all the compression is going to be on that bony prominence. So that's the law of Laplace. Laplace stated that the amount of compression is inversely related to the curvature of the radius of the curvature. So the actual more the curve, the more pronounced that compression is going to be. This is most important in thinner legs because you can create damage to these legs if you're not careful. Next slide, please. So, unfortunately, people just, my patients call it the lousy wrap job treatments. There are lots of different ways to wrap, and if you do it wrong, you're better off not bandaging at all because you create a lot of other issues, including lymphedema. Next slide. So there aren't any bandages really quite perfect. And in this particular study, you see every bandage that's available was looked at. And these are patients that were told you can just live normally and actually let's see what happens. And if you can see almost all of the bandages, except that are ones that are applied very cautiously and carefully, all slide or slip. So they cause problems. So you need to be vigilant with your patient if they're wearing bandages. And I don't let the family do them unless they prove to me that they can bandage well. But I don't really believe in that. I think a professional should apply these bandages. It's too dangerous not to. Next slide. So in a normal leg, like in this one, where the mean ankle circumference is between 23 and 40 centimeters, like a modified Udis boot provides 30 millimeters of mercury to the ankle. This is if I apply the bandage. Everybody's slightly different. And for a 4-layer, it's like 42 or 43 is the millimeters of mercury. Of course, it's gradient, so the mid calf is less and the upper calf is less of all. Next slide. But when the ankle circumference is less than 23 or in a tiny thin leg, these pressures can become very high and you need to be very careful. And this is the thinner legs are the ones that you need to be careful. And I tell when I teach and I bandage to these patients, I tell them all the time that if it's a thin leg, I want to do it. And if it's a thicker leg, I'll let you do it. And really, you can give them your cell phone number. They'll never bother you if the legs are big because really compression does very little harm to a bigger leg. But in the little leg and the thin leg, this one harm can be taking place and you need to be just super, super careful. Next slide. So there are limitations to compression, and that will lead us into using these intermittent compression devices that I'll show you, because in a lot of cases, that's the go-to, in my opinion. So you need to really apply by a trained staff. It has negative consequences because you have to leave it on a week, and patients don't really like it. It starts to sink, or they have a lot of wound fluid build up in there, and the patients tell me all the time, gee, doc, I want to go visit my family and I have to wear these darn bandages. So it's a nuisance. And there's a high variability of pressure depending on who applies them. And if it's the same person all the time, like I said, that's really job security. It's the best way you can do that. Next slide. So pneumatic compression therapy has been used since the early 50s, and this provides a terrific option for treating these patients in really a wonderful way. It's been used since the early 50s. I like a gradient sequential compression, which is really the ones that are available now. They have multiple chambers that actually squeeze first at the ankle, then at the calf, then at the thigh, and they actually sort of milk the lymph and venous blood up the leg. It's very similar to walking. If you do good heel to toe walking, which these patients have a hard time. Picture this: if you have a lower leg ulcer, after a while you either limp with it or you begin to shuffle. You don't really walk well anymore. So you lose this ankle, this good ankle flexion that you need for good venous return. So you need good heel to toe walking, and these patients often can't do that. And if they're immobile, wheelchair bound or bed bound, this is the answer. It actually allows them to do so well. You can use it with or without compression bandages. I like using it with short stretch bandages because it's even better that way, but you can even use it without, and the best results are seen after 6 weeks of therapy. Next slide. So I don't want to go through the slide, but I can tell you that the amount of evidence that proves that intermittent pneumatic compression works is very sound. So it's really an evidence-based therapy. Next slide. In every venous study that has studied intermittent pneumatic sequential gradient compression on these patients, in every study, the outcome was faster healing. In every study that's been published, there are no other studies that show no healing or even insignificant. These are all significantly better healing wounds when you use IPC for these ulcers. Next slide. I like using a durometer and tell you how well the pump is working and how often your patients are using it, how compliant they are with it. Of course, now a lot of these pumps come with a little diary built in that tells you exactly how long they were used, but I love using a tonometer. A tonometer tells you the softness of the skin. So when you first put it on, you can see this is work by Seleska and others, and Olszewski, show you very clearly that after 1 month of IPC, it softens the tissue at almost every level. This is me with a patient looking at their skin. These tonometers are inexpensive and really easy to use, and they're digital reading as well, and they really tell you how you're progressing. Next slide. I want to tell you some results that we had from a recent trial that we did on hard to heal venous ulcers, and these were 52 patients in this clinical trial. Next slide. And this is just the first slide I wanted to show you, just to show you edema. So edema doesn't improve immediately, but after a while it gets better and better. I look at 8 weeks for the actual tonometer or the actual durometer of the skin at 8 weeks, but I like 16 weeks to really look at compression, because there you can see the difference is incredibly marked. And believe me, that people tell you, well, where's the evidence behind that? Well, this is just not evidence. But when you look at these pictures, you say to yourself, well, gee, I don't need to have a literature on a clinical trial showing me that I need a parachute to jump off a plane. I mean, this is obvious. This is obvious evidence. And the obvious evidence is very clear. These are our data showing that after 20 weeks, you have significant edema control. Next slide. So in this study, we only wanted to look at hard to heal ulcers. So the ulcers had to be big and they had to be old. We call them BOWs, or big old wounds. They had to be big and old. And these were all non-responders that failed healing with compression alone. Next slide. So this is the worst of the worst, and I just want to show you some data here. This is time to closure by 8 months, and the control is the blue and intermittent pneumatic compression pump. This is with a Bio 2004 4-chamber compression, intermittent pneumatic compression device with a full leg sleeve. And you can see that the healing rates are dramatic. They're simply dramatic in the number of days, and these are wounds that haven't healed with other compressions before this. Next slide. This is pain. This is the very first time that we started to really look at the quality of life measures that these patients have to deal with. But let me tell you, the pain of having venous ulceration is notable. And in some patients, the size of the wound is insignificant. The pain is absolutely there. And this is an example of beginning to use the intermittent pneumatic compression device at 1, 2, and 3 weeks. Every single aspect improved pain in every single aspect. After 4 weeks, it turns out that that compression alone does help the pain, but it takes a much longer time than it does when you use intermittent pneumatic compression. Next slide, please. So this is another study that Eric Lulov and I did, and this looked at 98 patients with venous hypertension and insufficiency, and these are patients that were placed on either an intermittent pneumatic compression device or static compression. And look at pain after 12 weeks, significantly improved, statistically significantly. Look at edema, significantly improved, and inflammation improved in almost every aspect of these patients' lives. So these patient-centric outcomes are so crucial. Sometimes I concentrate much more on these than actual healing, because if you take care of the symptom, healing will come along. But patients with symptoms that have these problems can't manage staying compliant when they are in pain. And this is just something that obviously as caregivers you all know. Next slide. This is work by Sapan Desai, who actually looked at 190 or 192 patients, and he looked at the quality of life as measured with an SF-36. It's a short form of quality of life that measures physical functioning as well as social functioning and really pain. And in essence, in every aspect except emotional concerns, intermittent pneumatic compression was superior and actually improved every aspect of these patients' quality of life. Next slide. So there are lots of advantages for IPCs, and I don't have to tell you all of them. I went through many of them, but it's proven and safe at home. I've never had a side effect. There's a couple of things you've got to do to be sure, but they're not difficult. They reduce edema. The one thing that patients like the most is that it improves fibrosis. So it actually softens the tissue. It makes it less hard and less scarring. It improves the result. Even if you have your patients using minimal manual lymphatic drainage or comprehensive detoxification therapy, in all of these cases, even with that, when you use IPC, it improves those results. It's proven to reduce lymphedema. Obviously, I showed you about the healing of venous ulcers, pain reduction. It relieves restless leg syndrome, and it's really covered by most insurances and in some provincial healthcare plans in Canada. But here in the United States, just about if your patient fails 6 weeks of therapy with compression, with standard compression, and is well monitored, you won't be refused a pump. Next slide, please. So these are the devices I've used in the past, and I've used mostly the 2004 because it's just an absolute winner. And let me tell you, in all the studies I've ever done in the Bronx and in Newark, New Jersey, with my patient population, you can imagine these poor folks, they live in crowded apartments, difficult situations. They don't have great health IQs. And let me tell you, the devices work. And I never had a failure of one device in all the years, except one time a patient brought one in where the tubes that connect the sleeve to the actual pump had little marks, and they were bitten. And I asked, well, what do you think happened here? And we were looking around and asking the patient, and it turns out that these little hoses were bitten by rats in their apartments and actually destroyed the ability, because it destroyed the actual hose, the actual tubing in the device. That's the only time I've ever seen these devices not function well. The 2008 is an 8 gradient pump that's much better if you have lymphedema together with venous insufficiency, and it works so well with secondary lymphedema. And 3008 is programmable, so if you have a painful wound or a painful area in the leg, you can program these particular ones, this 3008, so that you can actually have it so it doesn't squeeze as much in one particular area. Next slide, please. So there are many garment options, and my preference for these venous ulcer patients is a full leg garment. And it's preferable for me for them to use it laying down, like on a couch with a pillow, or in any kind of easy chair. When the legs are down, you can still be successful, but it won't be as effective. Half calf or mid leg or half sleeves are also quite useful for patients who don't have really pronounced disease, for those with very minor problems, and it works quite well. But there are just about every type of, and they can be custom made to fit as well. Next slide. I like this cryobio. I've only tried it once or twice because it's kind of new, but this is a patient that has venous disease. Obviously, you can see there, but they have a bad rash called, obviously, most of you know what that is. It's a venous stasis dermatitis. And this is a patient that was treated with an actual cold compression, the cryobio, with a topical steroid for 1 week. And look at the difference in inflammation in just that time. So this is something that you consider when you have patients with very painful or very severe rashes. Next slide. So the contraindications you should know, if you suspect DVT, especially if it's a recent DVT, you need to really not use it at that time. However, for very long-standing DVTs, it's totally fine. So doing a duplex before you start on any of these patients, unless they have an excellent history of being able to tell you that they didn't have a DVT, it's always good to rule it out. If the patient has class 3 or 4 congestive heart failure, you need to use it carefully because it could cause them to lose their breath more. I like to use, in this particular case, 1 leg at a time, just to be consistent with talking to them and seeing if squeezing the 1 leg is affecting their ability to breathe well. If you have an abdominal or pelvic mass or any kind of lymphatic obstruction, you should rule it out. I always, have the patient go get an ultrasound and make sure you rule out an abdominal or pelvic mass. If you have active cancer, of course, this moves fluid around, so it's just a cautionary method. Of course, pulmonary embolysis, thrombophlebitis, cardiac failure, pulmonary edema, or ischemic vascular disease. And even with ischemic vascular disease, I've used it in patients that have ABIs of 0.5 at low compression settings, and they do quite well. But adverse events, if it's used correctly, they're extremely rare. You don't see very many adverse events. Next slide. So frequently asked questions about venous ulcers. People always ask me when I lecture on this is, what about elevation and leg rest? Well, you're not like the cartoon. Don't elevate your legs above your heart, because that's just going to tax your arterial system. Just elevate to the level of your heart. When your legs are level with your heart, your venous pressures are 0. And that's really the best you can get. Compression bandaging, excellent if they're applied by someone who is knowledgeable about applying bandages. Support stockings work quite well, but they're hard to put on, and these patients really have a very difficult time with them. However, once you're healed, that's the way to go. And I tell the patients all the time, when they get easy to put on, they're no good anymore. Exercise, heel to toe walking, absolutely the best. And good long steps in a nice air-conditioned, smooth floor environment. I tell them, go to the grocery store, grab a grocery cart, and just go up and down every aisle. And early in the morning when there are hardly any people there, and then walk out with a carton of milk. This is an excellent way to improve your healing with good heel-to-toe walking. Wound pain is like a branding iron going on your leg. It's like a burning pain. And it's alleviated by elevation of the leg at level with your heart for 15 minutes. That pain goes away. That's why they can sleep. If you ask these patients, they will have terrible pain. You tell them, how'd you sleep last night? Well, it took me about an hour, but I fell asleep. That's because the pain is gone in about 20 minutes when you have 0 venous pressure, 0 venous tension. So that, again, is a key. Better than any pharmaceutical, better than any analgesic. It works absolutely great. Time to healing, that's a hard thing to tell you. The size of the ulcer and how long they've had it is the real truth-telling device, but I always try to pick a holiday, depending on how long the wound is there, and try to give them some hope that we can get it at least to progress quite well by that time. So it's very unpredictable. And footwear for these folks, they all wear their own footwear. And they all wear chancletas or comfortable shoes that are useless. You need an extra depth shoe, a shoe that covers all the way in your foot, like a good sneaker or a really good fitting extra depth shoe that's properly adhered to the foot so you can walk heel to toe without a problem or without this sandal or footwear falling off. Next slide. About IPC, the most frequently used questions are here. Say, Doc, can I use the pump over my compression bandages? Absolutely. And I do it constantly. Like I said before, I think that's what even works best if you use it under with short stretch bandage. Can IPC be used on patients with both diseases? Yes, this is the answer for these patients that have dual disease. This is much better than bandaging alone. Can intermittent pneumatic compression be used on a patient with DVT? Yes. If it's established and the clot is old, yes. Can IPC be used on patients with congestive heart failure? It also can, but you have to be vigilant and try to use it a little bit at a time. You're keeping in communication with your patient to see how they're breathing and how they can tolerate it. As far as symptom management and palliation, boy, you saw the slides. It's incredible. It's a no-brainer. These patients all do better in their quality of life when they use intermittent pneumatic compression. How do I know my device is working properly? The softness of your skin. Once the skin begins to get softer, you know you're doing the right thing. How should I wash my sleeve? Soapy, washed off with soapy water, and I like Dove's unscented soap and a little bit of water, and just wash it carefully, and then rinse it with a different cloth that just has water on it, and that works really, really well. And just let it air dry. What happens if I leave it on too long? It's not going to hurt you to leave it on too long, and most of these devices now have a little alarm on them. But I like to use it twice a day for 1 hour. 1 hour, twice a day. Should I sit or lay down? Laying down is better, but you can lay down and watch TV or put a pillow behind your back. That's totally fine. But obviously, you know about venous pressure. The less pressure there is, the harder the pump has to work. My insurance pump will not apply. My insurance company will not approve the pump. What can I do? You need to mention to your physician that they may need to provide notes as to you not healing in a timely period, or provide a letter of necessity showing that there's evidence that will help heal my patient, and you won't be denied. This is something that you just have to understand. We're in, medicine is expensive, and nobody wants to pay for it, so it's kind of hard, but this is something that really has substantial evidence that it works. Next slide. So our sponsors, Paradigm, and I want to obviously thank both, and Biocompression Systems, who sponsor a lot of my studies and who I work with very closely with. They're fabulous people. Every product is made in America, and just wonderful, wonderful people. You can't believe how many patients weren't able to pay, and my colleagues at Bio were able to help these people out. So thank you very much, and I'll be happy to entertain any questions you may have.
Wonderful. Thank you, Dr. Alvarez. So if anyone has any questions, feel free to use the chat function or just unmute your microphones. As well, this is all of Paradigm Medical's contact information. If you have anything that comes up later on after the presentation, feel free to contact Svetlana. Her email is here, and we'll be happy to address whatever concerns that you have. If you're interested in finding a local dealer, please reach out to us. And then as well, we offer a certified pneumatic compression training fitter program. For those of you who are interested in becoming a dealer, you can also reach out to Svetlana, and she will work with you on getting the training for that. One other thing I wanted to clarify regarding questions about how to wash the sleeve. We just want to make sure people aren't submerging the whole sleeves in water, and just use a towel to wipe the garment down with a little bit of soapy water. That's the only caveat, just because you don't want to get any water in the hoses. because the hose is attached to the sleeve itself. Any questions? Okay, so we got a couple questions. With regard to cost, Kieran, feel free to reach out to us at Svetlana, and we'd be happy to speak with you about that, depending upon what the needs of the patient is. It will depend on which garment is recommended and which pump. Yes, we have recorded this presentation and will be distributing it to everyone after the presentation. Any other questions? We have Dr. Alvarez here. He has a wealth of knowledge. So if there's anything that anyone would like to get clarified, I would use the opportunity now. Is there anyone else? Alrighty, well then I guess going once, going twice. Thank you everyone for your time here today. Thank you once again, Dr. Alvarez, and for your patience with managing our webinar system here. I know it can be a little bit frustrating. We need to find a better solution because this seems to be quite technically difficult.
Yeah. So yeah. Thank you.
Alrighty, so this with that, I will conclude the webinar. And if anyone has any questions, please don't hesitate to contact us at Paradigm Medical. You have all our information. We will also follow up with the actual recording to the presentation, so everyone can use it as a reference in case there's anything that you missed or would like to refer back to in the future. So once again, everyone, take good care of yourselves, and we hope to see you at one of our future events. Bye-bye now.